Well, thank you, Michelle, for joining us. So the premise of this summit has been Crossroads, and one big component of that being oncology and rare disease. Many people ask why Axiom focuses in those two, and our main answer is unmet need, which is what I talked about this morning. But when it sort of comes to brass tacks, almost everything is different about these two indications.
Sort of.
Many things are different. I've tried to pull out a few themes where I think there are some things that overlap. And maybe we could talk through sort of these ideas and love to hear from you, your thoughts on if there are learnings from one therapeutic area that we could use for another. As we get started, do you want to maybe give a quick overview of your experience in these two diverse therapeutic areas?
Sure, happy to. Thank you, Anne, and thanks for the opportunity to talk about this important topic. So I'd say, I think my career has kind of been in three parts-ish. The first part was actually here in the sort of Boston, Cambridge biotech sector, where I started my career actually in the cancer clinical trials unit of Beth Israel Deaconess, and then moving into biotech, also in oncology here, where I had the opportunity to launch Velcade when I was at Millennium Pharmaceuticals. And then I got my MBA and I made my career shift to big pharma. So this is like Act 2. And then I've been at BMS for 10 years, AZ for 5, and then Novartis for 2 years. Almost all of that was exclusively in oncology, either in-market US, in-market ex-US, or above market in regional or global roles, thinking kind of long-term strategically about different portfolios within a company. And then my son was diagnosed with Duchenne. And, when that happened, and Duchenne, for those who don't know, is a rare genetic disease. It's a progressive muscle wasting disease. Caused by a genetic mutation, which was not an inherited mutation. It just happened to be a de novo mutation in his case, but oftentimes is inherited. And when he was diagnosed, it definitely sort of inspired Act 3 in my career, which was, upon reflection, when, something so meaningful in my life occurred, I sort of realized that although there is, of course, tremendous unmet need still in oncology, that in the 20-ish years that I had been in that space, we saw the introduction of targeted therapies, we saw the introduction of many immunotherapies. 5-year survival rates have significantly increased, which is phenomenal. There definitely needs to be more. But I feel like I had made some contribution during that time that I could be proud of. And I was very much discouraged by the sort of lack of innovation that was happening in the rare disease space, especially, I think it was day one that we got the official confirmation of his diagnosis. And I went to clinicaltrials.gov, as I have always done as an oncology commercial exec, to see what was going on in the field. And he was eligible for 0 clinical trials. So I was like, that cannot possibly be the case. I need to do something about this. And I felt like if I spent 20 years trying to push things forward within oncology, I wanted to spend the next 20 years doing the same thing in rare disease. So that's what brought me to Alltrna, which is in the flagship pioneering ecosystem. And Alltrna is a tRNA, transfer RNA platform company that is looking to engineer tRNAs in the first instance to read through nonsense mutations, which occur about 10 to 15% of all genetic diseases. And what's really unique about a tRNA is that a single tRNA can actually be used across maybe hundreds, at least, if not more, different genetic diseases, because we see the exact same mutations from one disease to the next. So putting that sort of in the kind of more familiar context of the oncology space, it's like a similar strategy of you target EGFR. EGFR happens in lung cancer, but it also happens in gastric cancer and some others as well. And you can use the same therapeutic perhaps in those different diseases. It's the same kind of strategy, I'd say, with what we might be able to do with our tRNAs. And so that to me was like a very powerful aha moment when I first understood what the company was trying to achieve, because I immediately could sense the impact that it could have on many, many, many different patients, especially those patients who might have a rare disease. I mean, Duchenne happens to be one of the more common of the rare disease, but there are ultra rare diseases that have zero, there's not even a standard of care, right? I mean, there are no therapies available for those patients. And so the idea of maybe being able to bring a therapeutic forward that could address the more common of those genetic diseases, but also the ultra rare, was a very powerful proposition for me.
Okay. Thank you for that background. Very helpful. And it is quite a story of the transition from Act 1, Act 2, and Act 3. Hoping to get some of your thoughts on how benefit is measured in these different worlds. In cancer, we have overall survival is the king, has been the king for a very long time, some of the other survival metrics, but also particularly for slow-growing cancers, an increasing reliance on some of the surrogate endpoints and the accelerated approval pathway, which rare disease often also is relying on biomarkers and surrogate endpoints and the accelerated approval pathway. Are there any lessons either from rare disease that slow-growing cancers could learn from, or from aggressive cancers that some of the faster progressing rare diseases could learn in terms of what works for measuring benefit?
Yeah, and this is where things are really tricky. In the oncology space, it's relatively straightforward, right? You've got RECIST criteria. You can measure overall survival. I would say overall survival has become king in today's day and age, but it wasn't always that way. And when I started off in this, my career in that space, that wasn't necessarily true. But we've kind of graduated because now we have enough medicines to really differentiate, some that help patients live longer and some that maybe do not do that as well. We're still in that sort of like early phase in rare diseases, right? Where, having the benefit of having any therapy that you can measure survival with would be a truly phenomenal thing, but those therapies actually don't really exist. And so, at least in most cases, I'll speak in some generalizations that might be different in, certain rare diseases. And so we can't really trust, or rely on something that is so black and white as that. Even when it comes down to, other types of surrogate endpoints. So we've talked a little bit about biomarkers, especially in the previous session. Now, PD-L1 was not a biomarker until it became one. And we're sort of in a similar case with most rare diseases. Like some biomarkers are being measured clinically because that's all clinicians have, but those biomarkers are not validated at all. They don't really know if they go up or if they go down. Does it really mean anything in terms of the overall sort of progression or, determination of, how a patient is faring. And so lots of that still has to get worked out across many of these different diseases. So I think there are lots of tools, right, that can be looked at from, the oncology space. The accelerated approvals there, it's an impossibility really to design a clinical trial that has a control arm, right? And so we really need to be thinking very, very differently about how to monitor patients and how to measure benefit and safety in them.
And has there been any successes on the rare disease side that could inform oncology, or in your view, is this really mostly a one-directional learning process?
Well, I'm not so sure, right? I will say one of the actual key things, and I sort of referenced this a little bit in my introduction, one of the key sources of inspiration that I'm taking from oncology is actually how we develop some of these medicines. In fact, how we're planning to develop our tRNAs using basket trials. So similar that we've seen with Keytruda has one of these indications. There's actually, I think, 5 or 6 different oncology products that have all led to indications with a basket trial approach. This is something that we believe that we can do with our engineered tRNAs and could be very beneficial for patients. I also think, though, however, one of the strategies that we are looking at in the way that we do a rare disease clinical trial is it possible to actually use an individual patient as their own control, right? And that I think is something that I think could be very differentiated in an approach. How that really works in the oncology space, I'm not entirely sure. But there are ways in which, like, we're thinking about that. Like, do you measure patients who are, for 2 or 3 months, and what kind of, let's say, metabolic crises they're having or decompensation events they're experiencing prior to entry into a clinical trial, and then you give them a therapeutic, and then you see how they do for the next 2 or 3 months. I mean, how something like that might be able to work in an oncology setting remains to be seen, but that is, we're sort of forced to think creatively in that way to try to figure those things out, because this heterogeneity that you see in oncology is like 10-fold or 100-fold in rare diseases. And so designing those kind of, well-controlled clinical programs is not necessarily as achievable.
It's like what we were saying earlier, the lack of resources can be the inspiration for creativity.
Well, maybe so.
So within the rare disease space, the word biomarker can be used in so many different ways. It can be used to identify different patient populations. It can be used to understand the way the different patients are going to be moving forward with their natural history. How is it being used in clinical trials right now? And are there certain rare diseases that you think have done a really good job of using biomarkers to improve outcomes for patients, and others maybe where it's fallen short?
Yeah, I'd say that, one of the more common rare diseases where there has been innovation is in PKU, which is probably a disease that many of you are familiar with, a metabolic disease. And the biomarker that's being used there is phenylalanine. So does a drug lower phenylalanine levels in patients? Yes, no. And does it actually bring patients into a more controlled state rather than where the phenylalanine levels are really high, and then the patient's not really controlled and, unfortunately then has to take this very burdensome diet in order to basically survive. And I'd say that's probably one of the best examples in the rare disease space where that biomarker is clearly validated. Like, clinicians know that if the phenylalanine levels get to below, I think it's 320 micromoles per liter, then that patient is well enough controlled that they might be able to liberalize their diet a little bit and maybe eat like a hamburger, especially if you're a teenager, which could be very compelling. But that's not true for all diseases. Like, that's one case where that's true. And there have been, there's precedents now for clinical trials that are measuring phenylalanine levels at the primary endpoint and have led to some approvals, which is great. So there's a roadmap there. And now we just need to make sure that we sort of, follow a similar roadmap where possible and apply those learnings. But like I said, not every rare disease has a well-characterized biomarker. And even where there is a well-characterized biomarker, it's not validated, because actually the validation of a biomarker actually comes when you have a clinical trial and you're actually
from the biotech.
Right. When you're actually bringing a novel innovation, or you do it in context with the innovation. And if there has been no therapies approved for those diseases, you're really starting from scratch there.
Mm-hmm. And one other sort of context for biomarker, maybe segmentation, that we see in both rare disease and oncology is that there might be particular genetic tests or other tests that you can do up front and say, we know different things about these patients. In oncology, we've got HER2 low, ultra low, HER2 negative. In cystic fibrosis, you have a bunch of different genetic variations. What are some of the pros and cons of trying to take a all-comers approach versus starting with the smallest group, maybe where you have the greatest confidence of success, and building from there? And are those similar dynamics in oncology and rare disease, or are they importantly different?
So what I would say is, I feel like, just reflecting on the last 20 years, like, we have made so much progress when it comes to doing mutational analysis for oncology patients pretty much across almost any tumor type, which is great. It's not perfect, but it's well over 50%, in most cases, which I think is awesome. That's not 100% true in genetic diseases. So I would say part of the diagnostic workup is just confirming, does the patient, have a mutation on the affected gene? Yes, no, therefore they have the diagnosis. But getting to the deeper level of the mutational analysis on what exact mutation is causing that genetic disease isn't universal yet. So there's work that we need to do across genetic disease to make that the case. And that is happening, and it's certainly happening more in terms of, similar what you see in the oncology space, the centers of excellence that are doing that more so than perhaps some of the other treatment centers. Now, what I would say is, in order to be able to select patients to, let's say sort of stack the deck in your favor for a clinical trial to be positive or negative, you also need to have enough patients to be able to make that selection. Keep in mind, we're talking about rare diseases. And when you're picking rare patients within rare diseases, we're talking about potentially very, very, very small patient populations that would just, number one, limit the overall business opportunity, which may influence whether or not you can get funding or the capital needed to secure the investment for that clinical program. But also, you might not know, how, whether or not having that selection is going to be meaningful at all, because there just aren't enough patients to be able to make that determination. So I'd say for the vast majority of cases, what we see in the rare disease setting is more of an all-comers strategy, I guess is how I, to put it in oncology lingo. Now, that will be different for us because we are targeting specific types of mutations that are consistent from disease to disease. So we will be looking for those patients that have those specific nonsense mutations in an individual condition. It's actually very interesting. What we do know about nonsense mutations in rare diseases is actually, patients that have these nonsense mutations generally are a more severe phenotype of the disease. So one could make the argument that if you have an all-comers type drug, you may not want to include the nonsense mutation patients because maybe those patients might not do as well because they're genetically predisposed to, having a faster progression, for example. In some ways, the flip side of that is with us being able to focus on those patients, it also increases the odds of us being able to generate some clinical proof of concept because the likelihood or the chances of observing a benefit might be higher because they are so severe.
And also potentially less heterogeneous.
Potentially.
A variety of other types of mutations all mixed together. One of the things that has come up is the difficulty of clinical trials, particularly in pediatric patients. And one of the ways you've just mentioned is the complete lack of trials in a particular disease, particularly for pediatric patients, maybe of certain ages. And in oncology, it comes through as a dearth of pediatric trials in general. And so pediatric patients often end up with an untested or unproven regimen. The physicians we were just talking with were talking about the importance of dose. And that is so hard in patients whose size is changing and where that hasn't been tested. How do you think those challenges compare? And are there any learnings from one to the other between rare disease and oncology there?
Well, in rare diseases, you got to figure out the pediatric thing really fast because, there are over 6,000 rare genetic diseases, and 80% of those diseases predominantly affect children under the age of 5. So that 80% of the market, right, is a pediatric population. So, you in many of these diseases, actually, there is no adult population for you to actually, do a clinical trial on. So you must be able to go through the requirements that are necessary to be able to enter into a pediatric setting, as quickly as you can. There are additional hurdles from a regulatory perspective, from a preclinical data generation perspective, in order to be able to get there. But I guess the benefit is that you can figure that piece out, get to a dose that could be safe and hopefully be able to provide some efficacy. But that is, I think, one of the, the challenges that comes with being in rare disease. If you don't know how to do pediatrics or you're not willing to go down that road, it's probably not the field you want to be in.
Yep, that makes sense. And you've already mentioned the idea of being your own control. Is there a way to evaluate what has happened to one patient for a while and then give them the medication, see what happens next? Dr. Langer, I believe, was talking about adaptive trial designs, where maybe we can try and get as much information as possible from pediatric patients by using smaller N sizes. Other folks have, bringing in the support of patient advocacy groups to help recruit and bring patients in. Are there any other ideas or innovations that are happening on either side you're aware of to try and make testing in kids more effective and safer?
Yeah, I mean, so all of those things that you've mentioned, I think are really important. In fact, the role of patient advocacy groups, I think, is probably the most important strategy when it comes to your clinical recruitment plan, more so certainly than in any oncology, tumor type that I've worked in before in the past. I would say that the other thing that I think that I'm a big advocate for, which we need to be doing better on, is actually newborn screening initiatives. So like right now, I mean, people have heard about newborn screening. Actually, we've tested for PKU. I'll come back to that example in newborns, at least in the United States, for over a decade now. There's a challenge with that because right now the regulations are it's a state-by-state kind of thing. And so some states are better at it than others. But also the stage at which a mutation or a disease is included in newborn screening is actually really too late. It happens when you have an approved medicine for a disease. So right now there's, in my son's case, Duchenne, there's now an approved gene therapy. And so now Duchenne is being added to some newborn screening panels in certain states. But the reality is like, if we're not finding these patients earlier, how do they even enter into the clinical trial in the first place? How do they get access to the clinical programs? And so I'm a big advocate for being much more aggressive in terms of how we go about screening kids who might be able to benefit from some course of therapy, whether that's an interventional clinical trial or supportive care that would be beneficial to them at a much younger age than, just waiting around until you've got an approved medicine. I think those kinds of things would aid tremendously. But, coming back to the oncology landscape, we saw a major shift in, testing for EGFR and testing for, lots of different, anything, HER2, BRCA, like whatever it was. And I think we'll get there, right, in the rare disease setting, but I definitely believe it's not something that, with the emergence of new medicines, it definitely will help accelerate it. But I do think that there are things that we can be doing and looking at the oncology space for where that has, actually made some progress that we can, take that into the rare setting as well.
But in the oncology space, those essentially became tested when they became clinically actionable, and that happens at the federal level.
Yeah, that's true.
Is there anything the folks in this room can do about the issue of newborn screening being managed at the state level and having potentially actual mutations that are not tested for?
It's a great question. And I do think that the policy approaches that are needed for rare diseases is something that's really just starting to pick up. Whether it's, the pediatric rare disease priority review vouchers, which I do think are very important incentives for companies like ours and others to even focus on rare diseases, whereby the populations are relatively small when maybe you can go after lung cancer, for example. But there are other policy things that I think can be important drivers of these types of activities. In fact, actually, interestingly enough, wearing my oncology hat on, right? One of the biggest challenges we're having right now in the rare disease setting is, will insurance cover some of these approved therapies for patients that are even within label? That is not happening in the genetic disease space. So dissimilar to oncology, where you have the NCCN guidelines, and generally anything that's in the NCCN guidelines is mandated, right, to be covered. That does not exist, right? And so I do think that there's a lot of policy initiatives, whether it's around newborn screening or around guidelines or, these kinds of things that we have to be able to do. And that, I think, is, on us as industry working with advocacy groups to then be able to do the lobbying that's required to influence those types of federal decisions. But yeah, I mean, there's a lot more that can be done that will, benefit many patients if we work together and make that happen.
Yeah, and move toward the improvements in screening for rare disease in the same way that we have in oncology.
Yep.
Be fantastic. The last sort of topic that I wanted to ask about is this idea of cure. And when you read the headlines about rare disease and these gene therapies are coming out and we're going to cure this and we're going to cure that, and then you say the word cure in a room full of oncology researchers and everyone shudders. It says we can't talk about cure in metastatic setting. Do you think, sort of, what is the emotional cadence around the idea of curing a disease, and how have you seen that play out differently in rare disease and oncology settings?
So I know we're starting to hear that word in certain contexts in rare disease, but I actually am also...
Still shuddering?
I'm shuddering, right? Maybe that's because I have 20 years of oncology experience shying away from that word, but it still makes me a little bit nervous. To me, I think there actually is more potential for that to be possible in oncology. So I'm actually going to push it back onto those who are really focusing in the oncology space.
We're starting to hear it every now and then. It
Which
comes
is
up
great.
Hodgkin's, maybe.
Well, because if a patient can be tumor-free for a certain period of time and it does not appear that is, rearing its ugly head again, I think you can argue that maybe that patient would be cured, and I would embrace that concept. In rare disease, it's a little bit different, right? You may be able to address that patient's genetic mutation, which would be phenomenal if that can be done. And if that can be done where it actually stops the progression of the disease, it would be a huge, huge win for any of these diseases. But in order for a cure to be a cure in rare diseases, I think you actually have to reverse the damage that was done. And oftentimes, these rare diseases start showing symptoms at a very, very early age. So that would really mean you'd have to intervene with whatever the modality is super young. People are even talking about maybe in utero, right? Maybe if you have an intervention that can stop progression and you can give it in utero, you might be able to do that, get to that sort of quote unquote cure where there really isn't any symptom of that disease in that patient. I think the bar for that is much, much higher in rare diseases than it is in the oncology space, where you can actually really measure. So I'd say let's get there in oncology, and then we'll figure out how we can translate that over to rare diseases next.
Is there anything else that you think would be a spot that we could do lessons learned from rare disease to oncology or oncology to rare disease, or have we sort of hit the highlights?
So, I'm going to come back to, we've got to be super, super creative here. When you have small populations and the total addressable market is pretty finite, you do have to make choices, and, you have to be really creative. Let's also keep in mind that's similar to an oncology patient who gets a very devastating diagnosis and is really only thinking about, gosh, how much longer do I have to live? It is actually very similar. Now I'm going to put I'm a rare disease mom hat on. We are willing to take risks, right? As a parent, I am willing to take risks on behalf of my child because the alternative is so dire, right? The alternative of an early death is so incredibly dire. That might mean I would be willing, and I'm going to sort of contrast a little bit what Dr. Langer said, perhaps, I don't necessarily know if I need to see the most robust preclinical data set. I don't know if I need to see the most robust phase 1 or phase 2 trial. I don't have that luxury as a parent. And I think that we can take more risk, perhaps, in the rare disease space because that's what the setting demands. And I do think that there, in certain contexts, that can be also applied in the oncology space too. And I come back to something that I said earlier in the morning, which is, do we need to have an animal model for every disease to demonstrate, in mice and then in monkeys? And then, how much of this do we really need to do? We got to get on with it. Patients are waiting.
Yeah. Thank you very much.